Everyone, to today's Lunch and Learn. We are so excited to have with us today Tim Santamour, and Tim has a panel with him, and we're going to be hearing from the Harm Reduction Collective. I know have a lot of questions about harm reduction and the work that the Florida Collective is doing. And then we also have questions about what we can do and what our different communities can work with. So with that said, Tim, I am very, very excited to introduce you and welcome. And everybody else, please go on mute.
Thanks, Pam. We're thrilled to be here. My name is Tim Santamour. I'm the Executive Director of Florida Harm Reduction Collective. We've been around for about 2 years now. I myself have 30 years experience in harm reduction, starting in Buffalo, New York in 1991, organizing and founding a syringe access program in concert with Buffalo Columbus Hospital there. And then I've worked in New York City with Lower East Side Needle Exchange, National Harm Reduction Coalition, Dance Safe, and a couple other organizations. With me on the call is Courtney Peters, who is our programs director, and Shelby Maders, who is one of our board members, and you may all know Shelby from as I refer to her as a Narcan queen. She's one of the folks that gets us the Narcan to distribute to folks. And Courtney is also an employee at IDEA Orlando, and I always forget your title there, Courtney.
I coordinate the Orlando Syringe Exchange, basically. That's what I do. And make sure we have everything we need.
So Courtney runs the syringe access program there with Hope and Help. So Harm Reduction 101, I'll start out by saying a lot of folks think they don't know what harm reduction is, but I've been practicing harm reduction for a long time. But what we're about as a collective is changing attitudes and practices across the state when it comes to people who use drugs and filling in gaps. It's one of the things you'll hear us talk a lot about is syringe access. And we talk a lot about syringe access because that's the one gap in Florida. Not that we have enough treatment, not that we have enough mutual aid programs, not that we have enough abstinence-based programs or housing as such, but one of the gaps in many areas is a syringe access program. So we'll talk a lot about it, but that's not all that harm reduction is about. Florida Harm Reduction Collective's mission and vision. Our mission is promoting health and safety for people who use drugs, their families, and communities across Florida. And our vision is a state where law enforcement, recovery, and harm reduction organizations work to end the harms associated with substance use. A state where drug use education, prevention, and treatment organizations work together to develop programs that further healthier decision-making by people who use drugs. And who we are. This is our core team. Ashanti could not be on the call today. She had a client, for lack of a better term, participant client, somebody that she had to help get in, but she is our project director and subject matter expert. She has lived experience in sex work, incarceration, a Black trans woman. Courtney, who's on the call, I've already introduced myself, and then we work very closely with Dr. Tyler Bartholomew at IDEA Miami, University of Miami. And we have a very close partnership with the IDEA Miami Needle Exchange Program in Hansel Tukes, Dr. Hansel Tukes as well. And one of our core missions is rolling out syringe access programs throughout this state and supporting that. But now my screen doesn't want to do what I want. Oh, there it goes. Oh, that's different. I'm not a techie person, so bear with me. So what is harm reduction? Harm reduction incorporates a spectrum of strategies that includes education, prevention, safer use, managed use, and abstinence by meeting people, involving people who use drugs or people with lived experience in drug use, where they're at in their use. Because harm reduction demands that interventions and policies designed to serve people who use drugs reflect specific individual and community needs, there's no universal definition or formula to implementing harm reduction. There's not a textbook on it. There's not a regimented formula behind services. It's really kind of looking at what's going on in the community, listening to what folks are asking for, and figuring out how collaboratively and collectively we put those strategies into place. What are its origins? Harm reduction really, as I started out by saying, communities have been practicing harm reduction for a long time. Any grandmother who takes on care of a grandchild because their child is in the throes of chronic use or chaotic use is doing harm reduction. For decades, church groups have had food banks or just breakfasts and lunch available for people to just come by. That's harm reduction. Not calling the police to an incident that may be more related to mental health. That's harm reduction. So communities have been practicing harm reduction, what we've kind of folded into harm reduction for a long time. But formally, harm reduction kind of gets going in the early 1980s in Netherlands with the junkie bomb. There was a hepatitis outbreak in the Netherlands. And people who use drugs started to want to curtail that. And so they asked the government if they could start a syringe exchange program. And the government said yes. Later on, kind of the international scene, harm reduction moves to England, where there were some heroin prescribing doctors and kind of pulling folks in and out of chaotic use, getting them into more managed use. And then getting their lives stabilized so that they could move on to getting them into treatment programs. At the time, there were very few options for treatment. It was abstinence or methadone. Getting folks stable and ready to do that was kind of important. Later on in the 1980s, we see much more activism around harm reduction and syringe access programs due to the AIDS epidemic. In some cities, such as Tacoma and Portland, Oregon, they started very early, 1988, with syringe access programs. New York City and some other places come later. But the difference in HIV infection rates among those drug injecting communities, from difference between Tacoma and New York, Tacoma's HIV rate for drug injectors has never gone above 3 or 5%. New York City's at one time was close to 75%, and over 80% Hep C positive. So we can see, the intervention of harm reduction early on in an epidemic versus a city that may wait or a community that may wait. Most recently, I think we can talk about Scott County, Indiana. It's the most kind of famous one that pops up, where there was a cluster of HIV infections among injection drug users and just a rapid expansion of those numbers. And then an intervention with a syringe access program, and we saw HIV rates slow, and we also saw referrals to treatment and folks accessing drug treatment increase. Later on in the 90s, hepatitis C emerged. It was something we used to, for those of us who are old enough, refer to as non-A or B hepatitis. Then we got hepatitis C and D, and I think we're up to H. So harm reduction started addressing more than just the needle. Now it became about other things that folks use to inject drugs: cookers, cottons, tourniquets, things like that, where we knew that traces of blood on those that drug-using equipment could transmit hepatitis C between two people who were not sharing needles, but just using in the same environment, using in the same place. Later on in the 90s, we see the incorporation of naloxone in overdose prevention in programs. Most notably, Chicago Recovery Alliance, a guy by the name of Dan Bigg, who unfortunately is no longer with us and passed about 3 years ago from an overdose. And then Dept Project in San Francisco, which was the first city-funded overdose prevention program, going out to where folks are using drugs, teaching them how to administer naloxone to each other, and then giving them naloxone, kind of making them the first responders, as opposed to, we generally think of EMS or police as first responders, but often drug users are the first on the scene of a drug overdose. And so if they have Narcan or naloxone and are trained in Narcan and naloxone administration, they can help the person while they wait for 911 to arrive. Later on in the 90s, we see the incorporation of recreational substance use into harm reduction. Dance Safe, which was an organization that I was executive director from 2001 to 2004, working with recreational users, weekend warriors, we might call them, people in the rave and electric dance music scenes, people in the music scenes, going to festivals like Bonnaroo and such. Doing a lot of drug education there. We knew that there were, we were seeing adulterants in the market, and educating folks about the risks of drug use, even if it was just casual use. And then also advocating for programs to be prepared that some of the folks that were using casually were going to transition to chronic use or chaotic use. And just being aware of that and trying to prevent that from happening and bringing folks back. In the 2000s, harm reduction starts to broaden itself into a more social justice movement, addressing health inequities in communities, looking at decarceration, nonviolent drug offenders that were better off out of jail and in supportive services, restorative justice, looking at communities that had been impacted by laws around the war on drugs, in trying to restore those communities. An example of that is states that have passed marijuana legalization laws are using tax dollars to go back in and refund community structures that were lost during the crack epidemic or during other heroin epidemics that we've seen in history. We started talking about inclusive body autonomous movements, the intersections of sex work and drug use. We know that's, there's a big overlap there. Not all sex workers are drug users, not all drug users are sex workers, but there is a cross community there, and we needed to be aware of those intersections and help build programs around them, getting folks out of sex work that didn't want to be in sex work, and just being there for them. And then so in the 2010s, with the increase of opioid overdoses in the United States, we see multiple communities coming in. Moms Against the War on Drugs, survivors of people who have overdosed. Other organizations start coming forward as OxyContin hits the streets, and we start seeing a broader types of communities involved, rural communities, suburban communities, and urban communities together. So where can we apply harm reduction techniques? They can be applied in a multiple of places and have been applied. As I said, I started out working at a hospital-based syringe access program. emergency rooms. We have tiers in a number of emergency rooms throughout Florida, getting folks into treatment. They're not always able to get folks into treatment at that moment. And so then they follow up later on when a slot becomes available. They keep engaged with folks where they're back out in the community and then fold them back in. Doctors' offices or social service settings. These are places where we can implement harm reduction. Doctors can talk to folks that they're prescribing opioids to for pain management and talk to them and their families about the risk of overdose, about the risk of transitioning from medical use of a substance to a dependence on that substance. Mutual aid and other service organizations, MARA or MAT supportive programs, harm reduction works, AANA, those all can incorporate harm reduction practices and techniques. We look at law enforcement in the court system, drug courts, law enforcement assisted diversion, community diversion programs. What many of us do when we're out on the streets and you run into somebody that's in chaotic use, we try to divert them into a program as opposed to just waiting for them to get arrested and accessing services at that point, which is a lot more difficult, makes it a lot more difficult for them to actually be successful at that treatment when they've got other stressors going on in their life. And street and mobile outreach, home visits, drop-in sites, so all places where we can incorporate harm reduction practices and bring people the services that they ask for as they ask for them. Courtney or Shelby, do you want to jump in and take one of these? I'm getting tired of talking.
Yeah, absolutely. Yeah, you're doing a good job, Tim. No, I'm everything you said so far has been great. Courtney's stuck in the rain. It just started pouring and she's outside, so I'll definitely take over. Yeah, so you've touched on everything so far. You've done a great job. We do a lot of stuff. So harm reduction, as Tim mentioned, isn't just one thing. It's, meeting people where they're at in different ways and through different channels. And I hate to just read from slides. So these are just kind of examples of different services that, where we can reach people and really work with them through the collective, through all of these different outlets here. And I'm not going to just read down the list, but we can go ahead and go to the next slide. I'm not controlling the slides actually.
Nope,
so.
I am.
Yeah, so some of the issues that kind of, go ahead, Tim, did you want to chime in again?
Go ahead, I'm sorry.
No, you're good. These are some of the things that if, we weren't here and working with people and giving them the resources and tools they need. These are some things that can result from different practices of, sharing syringes or, sharing in the same environment or using drugs at the same location. These are the things that can result. So we see hepatitis C or soft tissue infections. We see a lot of people without homes or people that, are looking for jobs and are not able to find them or seek them. And there's a lot of stigma that still exists. So people are not able to, get the resources and the tools that they need. And that's kind of where we come in, because these are some of the harms that are there that, that are solvable, they're completely curable. And if somebody has sterile equipment and they have the resources to seek a job or find housing, stable housing, they're able to, have their own journey of recovery and really just, live a great life, if these tools and services are provided. And again, they are treatable. I list those examples here. Same with HIV, criminal records, trauma. These are all things that we can address if those resources are available to the person. And again, through harm reduction and through the collective, we can meet people where they're at and provide these tools to them. And same with, the forever. Yeah, that's a great one. You can't recover from a fatal overdose. So different things we do include naloxone distribution, because with naloxone available, you're able to decrease the mortality from overdoses and really just give that person another chance to survive and to live and to seek healthier choices if they want to, if they're ready to seek treatment or not. That's, up to them. Because that's the big thing with harm reduction is we want to make sure that, people have a voice and they have a say and they know that they have rights as a human, regardless if they use drugs or not. They're able to make that choice for themselves. And when we're here just to be able to provide them again with tools or services or resources so they can make, healthier decisions or different decisions based on, their current needs.
So this is kind of like, a sort of start to talk about, the different types of community specific services that harm reduction tries to address. In a number of the communities listed here, if we think back historically in the providing of medical care, we've seen clinics or service organizations that arise directly out of the fact that the mainstream medical and treatment organizations don't necessarily address everybody. So we've seen women's health clinics pop up, women's specific mutual aid meetings and such. Lesbian, gay, or MSM specific communities where AIDS service organizations arose out of the AIDS epidemic that wasn't being addressed by the broader health communities. And we're able to offer approachable, low barrier services to folks. We know with BIPOC communities that there are health clinics within our communities of color that are also better at opening their doors and having and accessing folks or having folks access them to get the services they need to stay healthier. And more we're seeing, we've seen in a way, some of these things have ended up siloing communities. We struggle to bring everybody back together so that we have, we share information and share data. But these systems kind of arose out of the need to address multiple communities, multiple identities within people. And some of these folks, some people on this list, you could be more than one. You're just not one identity. You could be a person of color who's a sex worker and a lesbian and a drug injector. Those can all go together. And how do we look at our services? How do we kind of deconstruct our services to serve all these folks? And then, add on top of that, your use of choice and your drug of choice and your method of use. Services for heroin users are going to look a lot different than services for folks using party drugs. People who are injecting or skin popping, those interventions are going to look different than somebody who's smoking or drinking. So it's kind of all of these things that go together that make up a complicated matrix. Meeting folks where they're at, getting them to where they want to go. You have to have trauma-informed, culturally sensitive services to be able to listen to folks what they're asking for, and then all of the services that exist out there, you have to have a sort of cultural competency and an awareness of the variety of services that we have, and how do we plug people in? How do we, when we meet somebody on the street and they talk about, they need a home, but they want to stop using, do we know a Housing First program that we can get them in tonight, where they don't have to stop using tonight, so that tomorrow morning when they can meet with somebody, they can start that road towards recovery, towards the place they want to be. And it's important that these services be stigma and judgment free. Not everybody is comfortable approaching the medical system. We know, those of us with lived experience know the reactions that we got from doctors when they found out we were substance users. Those types of reactions sometimes mean somebody's not going to come back the next time they may need to, and then they fall out of services, and we kind of have to figure out how to go back out and get them. And if we can get them back into services before they're seroconverted to HIV or Hep C, before they've had an overdose experience or such. Because once that started to happen, now we're compounding on top of the stigma and judgment that they started out with. Now we're compounding trauma on top of it, or we're compounding a chronic disease that they're going to have to learn how to manage, while they're also trying to manage their recovery or their abstinence or whatever else place they want to be. So it's important to remember this matrix when we're talking about harm reduction services. And organizations don't have to be the one all be all for folks. That's the other thing that harm reduction tries to kind of push. You can be a housing first program. That's it. You don't have to be also a needle exchange and an MAT access program and you can just be one of these types of programs. It's just important to network with the other programs in the community so that we can leverage all of the services into one kind of streamline for folks as they come from the streets and move to where they want to go. Harm reduction outcomes, self-assessment for folks to keep them honest. Harm reduction sometimes is a lot of it is challenging what folks are talking about to you as you're with them, and challenging them, not push back to them, but challenging them to explain and to dig deeper within the reasons they may come up of why they can't access, whether they're looking to access a treatment program, or whether they're looking to be abstinent, or whether they're looking to how they're looking to change their life, to get to the nitty gritty of what service you may need to offer them. Somebody may come in saying to you that they want to access an MAT program, but do they really have the structure in their life if they're living rough, if they're homeless, if they don't have a regular income to eat and to maintain other things, how are they going to access programs that may require them to be at places at certain hours if they don't have transportation, things like that, and getting to the basis of, okay, if you want to be in this MAT program, well, that's across town, and how are you going to get there for your appointment and such, and working out and figuring out that stuff to get it in place so that as they start to move on and make their lives better, if they want to make those healthier decisions, that they've got the support, but one of the big things here is rules are rules, but how do we develop a plan to keep somebody engaged in our agency if they've broken those rules? Some of us, we're the only ones in the locality offering these types of services. So if somebody breaks a rule, and I've seen it involved, the biggest thing is if somebody's violent towards somebody else in the program, of course, that's an issue. And of course, they've got to be sanctioned in some way, but how do we still keep them engaged? How do we hold them accountable for their actions? How do we talk about restorative justice so that they understand what they did was wrong and why it was wrong? And then how do we bring them back in so that they can continue on the path that they're on? Eventually, I've talked with folks where eventually we have to ban folks from service. But just what little services we can offer them to keep them engaged is important. I'm kind of we're kind of done with talking. This is our contact information. I'll leave it up for a moment, but Courtney was going to share sheet with me, but I don't think she got it because it started raining.
I emailed it to you. You should have it.
Okay. Let me then pop out and see if it's in my mailbox.
Tim, and we have a meeting tonight, is that correct?
Yes, we do.
Awesome. We can share that information. We have a general body meeting for the collective tonight. We meet, we have a Facebook page. So we can share that information because we'd love for new members to hop on. If you just want to learn more about harm reduction, just like this webinar today, or, you know, see what's going on throughout the state because it's statewide. So we have all different, you know, organizations and counties represented. And it's usually a pretty relaxed call. We kind of just talk about different things that we're doing in our community for harm reduction and talk to the different SSPs that come on and peer networks. And it's a great group, and we usually have great conversations as well.
So I'm going to share this. This is a one sheet, and Pam, I'll send this to you. This is our one sheet on syringe service programs in Florida, and really, it's meant to be a drop-off sheet and an introduction to the idea of syringe services, and it kind of goes through, you know, the background of the Infectious Disease Elimination Act, you know, what national and international organizations support it. They looks also at you know, effective and comprehensive evidence-based studies that that exist and support syringe access programs, and then, you know, some of the costs associated with not having a program. You know, that an HIV infection is going to cost a county or a state $325,000, $4,000 over the lifetime of that person. Treatment of hepatitis C at this point is still $84,000 a year for the treatment. I think it's a 6-month. You know, in folks in Flagler, and this is specific to Flagler County. Flagler County in 2017 spent $17.8 million to treat hospital visits for folks with a history of injection drug use, whether that's overdose, endocarditis, soft tissue infections, or abscesses. That's the amount of money the county spent for folks who were uninsured, who needed to access those services. It also talks, you know, it talks a little bit about crime and syringe litter associated with syringe access programs, that syringe services programs, crime tends to decrease around the program. A lot of that because participants start to value the program and they don't want to put the program at risk. So they take their disputes everywhere, you know, elsewhere. And also a study in Miami before the syringe access program opened there and afterwards showed that syringe litter in parks decreased by 50%. So the idea that a syringe, especially a one syringe access program, it's putting syringes out into the community, yes, but it's also getting syringes back from the community. It puts a value on that syringe, and folks are much less likely to discard that because they know they have to bring it back to the program to get another one. Some of the programs in Florida are actually seeing more than 100% return rate for the syringes that they are distributing, because you can buy syringes at pharmacies or you can get them other places, and participants are still using the program to dispose of those syringes. So they're not tossing them, the syringes that they're not getting from the program, they're not tossing them back into the community. So it's helping remove litter and helping that safety issue. And then at the bottom of the one sheet, this is specific to Flagler and Miami counties, kind of taking a look at your HIV diagnoses, Hep C, and then drug poisoning. Not all the drug poisonings are opioid related or methamphetamine related, because the state doesn't break that data out. We are working on a program that will break that data out. But this is kind of looking at, as we can see for HIV diagnosis, Flagler County is on the upswing from 2018 to 2019. As far as hepatitis C, we're seeing this across the state, where hepatitis C is just going through the roof. You know, the unfortunate thing about this is it's 2-year-old data. You know, but also we all know that drug overdoses are going up. You know, we have seen a spike in fentanyl-related overdoses start in Lake County, come across to Volusia through Flagler into St. John's, and now it's hitting Duval County. And we've just watched data that just shows us how it's kind of come up the 95 corridor. And it's frightening. Unfortunately, we do very little talking across county lines about what's going on. And it's something that the collective wants to start doing, is to have meetings that involve everybody in the state, so that if we see a spike, if we see something new entering the drug market, we can talk about that sooner than later. We can talk about it hopefully before we see increases in overdose, and address it at the time. And then the other thing that's nice about this one sheet is that on the back of it, it has all of our references, published studies about the effectiveness of harm reduction and syringe access programs. And, you know, so this gives county commissioners or folks who may have questions about the effectiveness of harm reduction and why harm reduction programs should be implemented. It gives them a start of places that they can go to research it, separate from the collective. And we can also provide others. It's the one thing that I do on the Facebook page, is I try to share studies as they're published. And soon we will have a website up that will have links, and we're just gonna put links to all the studies as they come out, and folks will be able to research them and go to the academic sites or the government bodies that are putting out the studies and see the effectiveness. So that's all I have, Pam. Just that little bit.
Just that little bit, huh?
You know.
Oh, Tim, Shelby, Courtney, thank you. I know people have questions, Tim, so let's move right into the questions. And Karen, you want to kick us off? Because I know you have a burning question.
Well, so just this past weekend, we were privileged to be invited to give out Narcan at Rockville, which there was a lot of people there, needless to say. But several people came up to our table and asked for fentanyl strips, which are still illegal in Volusia County. So I guess my question is, are you doing active advocacy with the various sheriff's departments because right now in Volusia, it's considered paraphernalia. I'm sure everywhere else it is as well. But, I know I have a friend that took one pill that ended up being, because he thought it was Xanax and it was really 80% fentanyl, and he never woke up. And so if he had fentanyl strips, he probably would not have, taken that, because he was in, he was in harm reduction pathway of recovery, right? So I guess my question is there a strategy for, we live in Volusia County is very conservative, and every time I've talked to the sheriff about it, his concern is mostly the needle exchange. However, even with the fentanyl strips, he doesn't know 100% about it. We don't really get a straight answer from anybody in the county about fentanyl strips per se. And, I just was curious, there's a set strategy that can be used to at least get fentanyl strips approved in Volusia County, because I think it would be really helpful here. And
Shelby,
I basically asked the Department of Health here to take up the banner on this, because it's definitely a public health issue, rather than me and DRA being the ones to put the face on this, because we're just getting started. So that's my statement. Thank you.
Shelby, have you heard anything more on the state Department of Health trying to get the paraphernalia designation for fentanyl strips removed?
So that's a great thing that you brought up, Karen. It is paraphernalia throughout the state of Florida. So it's not just a Volusia thing, but it's the entire state. And it is a huge barrier to just the distribution and use of fentanyl test strips, because it is super important. And then to answer your question, Tim, I know that there are groups advocating to have during session, to remove that barrier. So they're no longer paraphernalia. I do not know of any state agencies that have taken it on. So I know DCF as a whole has not taken it on, nor has DOH that I'm aware of. They may support it. I'm very vocal and very supportive of making them legal. But from a agency standpoint, I don't know of any state agencies that have or are willing to take that on, just for very.
I know that at one point there was a question posed to the state attorney whether or not fentanyl strips were actually drug paraphernalia because they're not used in the use of the substance. So, and I don't know what the designation back on that was, or even if the state's attorney wanted to answer it. I do know, as Courtney said, I do know that there are folks advocating for changes in paraphernalia on the state level. And I've also heard many people with the Department of Health, within the departments of health or and such, talk about the need to lift this. So hopefully that comes. The one thing I'd say about folks who for an event like Rockville, folks that are approaching a table, they're probably more recreational users and such like that. And if they were to ask me for fentanyl strips, I would actually refer those folks to Dance Safe. And Dance Safe has a much better drug checking system than a fentanyl test strip, especially for folks that are testing something that could have an amphetamine in it, the methamphetamine or MDMA, Molly, ecstasy. They've got a much better system for testing it. And it's much more refined and will tell them a lot more. And those can be purchased in across state lines. They're the same testing reagent kits that police use when they're doing on-site drug testing. So they're pretty reliable in their accuracy.
Thanks, Tim. So we have two more questions. Tiffany's first and then Mary Ann. So Tiffany?
Not so much a question. I just wanted to kind of piggyback off of what Karen was talking about. I was actually grateful to be able to attend the higher education conference with Anna Reed and Recovery Schools of Central Florida, where we actually had a panel with the DEA agent on the panel. He was a DEA agent for about 25 years in the Orlando area. And that is what they are doing. They're pressing pills to look like fentanyl, Xanax, Adderall, Oxycontin, you name it, and they're pressing it. And, he was talking about that he did this undercover buy where this apartment was pressing, these fake fentanyl pills. And, when I'm talking to people about harm reduction and talking about, people that I know who are still using, I educate them on this, because 1 kilo of fentanyl is $50,000. Okay. It presses 600,000 pills. And the DEA agent stated that the average buy is $10 a pill. So when you do the math, you're talking these drug dealers, it's a $50,000 investment and they're making $6 million. And it's like, I tell people, do you think they really care if you die? Because they don't. with that kind of money. And then he did another undercover buy for cocaine, and it tested 80 to 90% fentanyl. So, you know, I just wanted to piggyback off of that, because that was something I learned and something that I found like extremely shocking. And, you know, just stuff I've been trying to educate people, and even talking to people at EDC this past weekend. You know, I even had people asking me, how much is your Narcan? And I was like, do you really think I'm going to charge you to save a life? Like, no, just take one. It's free. But I just wanted to just piggyback off of that and just let you guys know what I learned from the higher education conference.
Yeah. And one of the things that we're finding. Oh, go
Go
ahead.
ahead, Tim.
Mhm.
Okay, I just wanted to say that it's not a great solution. I understand like what I'm about to present, but we are hearing like colloquially that as folks have a card from a neighboring county, they are being protected, and it's really, we're seeing that you cannot distribute and do syringe services in a county without a program. However, if you come to a county with an established program and you have a card, legally, it's a very big gray area, so I don't recommend it. However, we have a lot of participants in Volusia County, and so far they have their card, and I have not had anyone arrested for it. So it's not great, but it is something that we can kind of offer.
So speaking of Volusia County, we'll move on to Mary Ann.
Hey, I'm so confused right now. So tell me, is it legal or isn't it legal? Because I know 2 places that are handing out syringes. So is it legal?
The Infectious Disease Elimination Act allows for programs to get authorization through the state to run a syringe exchange program where the syringes are being used explicitly for the use of illicit substances. It's not illegal in Florida for a pharmacy to sell a syringe to somebody.
Right.
It's not illegal to possess the syringe if the syringe is not for the use of an illicit substance. As soon as you kind of cross that mental barrier of illicit substance, then that syringe or cooker or cotton or it can become paraphernalia. And once it becomes paraphernalia, then it's against the law. So it's confusing because it's confusing.
Yeah, and it's a county by county basis, obviously, for each program. So if somebody is handing out syringes in Volusia County, I'm not going to tell them, but it is something that has to be established by a county commission.
I'm not going to tell on me either, but the point is, it's either we either have this passed and let's do it as a whole, or not do it at all. I mean, we can't, that gray area is not good.
Yeah, and Mary Ann, if you want to shoot me who it is, I won't tell anybody.
No,
but I'd like to be in contact with them. If you know who they are, I'd love to be in contact with them. The collective, we're funded, along with the University of Miami, is funded to help expand programs. So if there's a group of stakeholders in Volusia County that wants to examine opening a syringe access program under the law, we can help you through that process.
What about fentanyl strips? They're illegal too?
They're technically in this state, they're illegal. So, you know, and that's, yeah. So that's a little bit more complicated because that's a legislative thing. And we can't be, as a not-for-profit, we can't be involved in legislative issues, although we can support an organization. And I'm not sure what Project Opioid's position is on fentanyl strips, but they're probably more the legislative type of organization to push through this, or one of the law schools where they give their law students legislative tasks to, you know, kind of teach them how that works. It would be finding an organization like that that can actually advocate for this in Tallahassee and get it passed.
Could you get fentanyl strips from CVS?
No. We mail the programs we have that distribute them. We get them from BTNX Solutions. They run $1 to $1.50 a piece, so they're not cheap for somebody who's a chronic or chaotic user. But
Could the RCOs have them?
it would be, the RCO would have to make the decision and weigh the gray area.
Oh, no.
That's the thing. You've got to weigh the gray area.
Well, listen, it took me 14 months to get an exemption. I'm not willing to go back there. Sorry.
Oh, I hear you. I hear there's legislation in front of Tallahassee now to reduce barriers for peers in those exemptions, to make it easier for folks, to shorten the look back period, to remove a lot of the violations that made you ineligible, and hopefully that goes through. I know that
How many people are going to die before that goes through?
Exactly. But I know that some folks, and Karen would know, would know that there are some folks with Floridians who are recovered that are working on this.
Mm-hmm.
And yesterday, I did find out that Senate bill, the bill that you're talking about that's trying to eliminate barriers, does now have support from 2 people in the House. One is Elizabeth Fetterhoff, the other one is Diane Hart. And so it's bipartisan support is finally happening in the House. So it's really good.
Thanks to you.
So yeah, when that starts to happen, that usually is a really good sign that the bill will continue going through. So I'm going to move us along here. 2 things. I want to make sure that we've answered all your questions that we can possibly answer. And the other thing I want to say is, if you have never received an email from me or from Flagler OARS, please shoot me your email address if you want a copy of that sheet. Most of you are in my email list, but if you don't think you are, just type your email, please. Other questions?
See, Ken asked me directly to talk a little bit about what's needed for a syringe access program. And, just the short answer is the county has to pass an ordinance that allows for the program. And depending on the structure of the county, request for proposals would go out to organizations that were interested in operating the program. Once the program is selected, there has to be a letter of agreement between the County Department of Health, that organization, and the county commissioners. And lastly, there's a contract between the County Department of Health and the Syringe Access Program, or programs that want to open. We do a whole hour plus exploration of opening a syringe access program, that we would be happy to do. Sit down with whoever. Usually we ask that a group engage with law enforcement as soon as possible, if that's what you're interested in doing. Law enforcement is essential in getting a program passed and having an effective program. Their partnership, it's just needed. Our folks at Access Syringe Services programs encounter law enforcement people frequently. So having law enforcement on board is a great idea. In Miami, Idea Miami would say it's the one mistake they made when they started the program 5 years ago, that they didn't engage law enforcement early enough.
And we also, a couple weeks back, did a webinar on the steps to start a syringe exchange in Florida. I can send that to you, Pam, if folks would be interested in watching that recording to have like a little bit more in-depth idea, or we are always happy to jump on a call and talk about it.
Okay, thanks. Hey, Tim, the other thing that I wanted you to toot your horn about just a little bit is, right now, how many counties or municipalities in Florida do have a legal syringe exchange?
There are 5. currently now. There's IDEA Miami, IDEA Tampa, IDEA Orlando, the Spot, which is in Broward County, and Flash Exchange, which is associated with Rebel Recovery in West Palm Beach. There are maybe another 6 or 7 counties: Manatee, Lee, Pinellas, Leon, Alachua, help me, Courtney, that have ordinances in place but don't have programs open yet. Pinellas has identified the organization that's going to open the change, and they're in contract negotiations. And then Duval County has an ordinance coming in front of it, hopefully by the end of the year. And Inspire to Rise, which is a community-based organization in Duval, would be the organization there that would run it. But we're also talking to Pasco, Seminole, Volusia, Brevard.
Everyone else, Marion? No.
Marion, Nassau, Putnam. So the interest in a switch access program is great. It's excitingly overwhelming. But as we, if that's something Flagler wants to do, or someone that's on here from another county they want to do, get in contact with us. We'll loop you in so that we can start to build those stakeholder networks early on. Really needs everyone involved, because not one program, as we all know, can be one thing for everybody. And we don't want to overwhelm the program that wants to open the syringe access program. They don't have to be the end all be all for a person using drugs. They can set up memorandum of understanding and referral agreements, and such. And Ken just saying about Sarasota County, yes, Ken, Julia Negron has been bugging me for days.
Thank you, everyone. Any more questions or comments for Tim or Shelby or Courtney?
I'll add something in and I don't want to confuse people more, but something exciting to look forward to. If fentanyl test strips do become legal, and that's passed and they're no longer considered paraphernalia, we do have the okay from the federal government through like SAMHSA, the Substance Abuse Mental Health Services Administration. That's who we get a lot of our dollars from for grants at DCF, Department of Children and Families. And they did release a statement earlier this year and give us the okay to purchase fentanyl test strips. So once that barrier of them being illegal right now in Florida is lifted, we look forward to hopefully expanding programs at the state level to distribute fentanyl test strips to anyone, whether they need, whether they're at risk of overdose or at risk of witnessing an overdose.
That's going to be awesome, Shelby. We're looking forward to that.
I just want to put out there's something else that's going on that the collective is advocating against, is an 8 milligram naloxone nasal spray. 8 milligrams is a lot of naloxone to give to somebody, and can throw somebody into acute withdrawal instantly. If anyone has ever been given Narcan for an overdose and brought back in a harsh way, as some people have done to folks in the past, you know what a horrendous experience that is. And it's just not a good idea to increase the dosage. The 4 milligram allows us to give people multiple doses. Wait a minute, do rescue breathing or heart, compressions. If this company that's pushing 8 milligrams, it's just nationally, the overdose network of organizations nationally is pushing back against it, because we just think that it's going to end up then being a deterrent to folks seeking to be revived. We're looking to revive somebody to get them breathing, not to shock them into being, or to punish them for being a drug user. So just to put that out there, it's bad.
Thanks, Tim. That's good, good to know. Anyone else? Well, again, I want to thank you, Tim and Shelby and Courtney, for being our panel today. This was awesome. I'm sure we're going to ask you to come back and dive a little deeper into syringe exchange someday. But in the meantime, I'm thrilled about the work you all are doing, and thank you very much. And everyone else, thank you for your time. We sure do appreciate you taking an hour out of your day to come learn a little bit more about the recovery movement. So thanks, everyone. Have a great one.
Thank you, everybody, so much.
Bye.